Hello, friends. Let's talk about management of a patient with head injury in the emergency department. Like with most of the patients, we first need to have a systematic approach and resuscitate if required. Then we need to identify the problem and define its extent and manage accordingly. And then we have to make a plan and consult any appropriate specialty and then decide where they would be moved to. So, saying that, let's talk about the first section, which is the approach. Now, suppose a patient who has just been brought in or has come in and who has is presenting with head injury. Your first bit is your triaging, and in triaging the key thing is any person who has suffered a head injury is bleeding on arrival, or you check their sensorium on the AVPU scale, which says if they're alert or responding to voice or responding to pressure or painful stimuli or unresponsive. So any person who is not alert or just being in either V, P or U is or bleeding should be triaged on a priority basis, and then an immediate primary survey should begin. And we know in a primary survey we take the ABCDE approach. So the point is that any person with head injury, you just don't begin with the wound or the injury itself. You treat the patient as a whole, and that is why the primary survey. So you move on checking the airway, their breathing, their circulation, and record their vitals and start correcting any things at that point. If there is any bleeding going on, you need to apply direct pressure and control the bleed. You need to, and then when you move on to D, which is the disability check, the three most key things that you should check in every patient is their GCS, which is scoring from 3 to 15, checking for eye response, their vocal response, and their motor response. And remember these 8, 13, and 15, meaning that any patient who has, if their GCS is 15, which is the maximum and the best GCS, then that's a green sign, good thing. Then, but any patient with a GCS of 13 or less, then they would be classified as moderate, and anyone who has 8 or less would be considered as severe head injury. And so you mark their response and document their best possible GCS at that time. You should check their eyes and check if there is any bleeding, any contusions or swelling around one eye. And if possible, yes, check their pupils. If the pupils are round, reacting equal, or they are asymmetrical, and if they are reacting to light or not, and check their eye movements. And then the third thing that you check is focal neurological deficit. So check if there is one side or one arm or one limb that is not moving, or so those things might lead us to a very brief but important assessment of the disability. Other things to consider is a C-spine injury, checking their blood sugars, and considerations if they have taken any toxins or alcohol. But as I said, documenting these three things is important for our plan. And then we take the history as taught in the advanced trauma life support courses, the sample history, which is signs and symptoms, or basically what happened to the patient, the mechanism when it happened. That will come in E basically, but the events, but signs and symptoms, what is the current problem of the patient, and then A, document any allergies, their current medications, and an important consideration of any anticoagulant or blood thinners here. their past medical history, if they've had any significant comorbidities and any bleeding disorders or previous neurosurgeries. Then take the document the last meal, time of last meal, or and then E is the events leading to the current situation, which is like how did the injury happen, where did it happen, who saw it, how was the patient brought to the hospital, and any events that happened. Has he been deteriorating since? Has he been alert? So these are the things that you do in your initial bits. Now, some people, as I said, this is the approach that you need to take. Some people sometimes directly jump on the wound and they think that closing the wound is a priority. Mind you, your priority in the primary survey is to control the bleed. And as I said, doing the primary survey and closing the wound can be always be done in the secondary survey of the patient when you stabilize the patient. So that can be done after you stabilize the patient. Now, once you've done this, now you are now thinking head injury. What should I do next? The next thing is to determine if this patient is a candidate for a CT scan or not. Now, if someone who has suffered a head wound but is alert and talking all fine, then you would be thinking, should I scan or should I not? So then is where our red flags come into red flags of head injury help us. So any person who has a GCS of as I said, 15 is fine, but if they have a GCS of 13 at the time of injury, less than 13 or less than 15 after 2 hours, so that is so basically the drop in their sensorium is a consideration. If they've had any seizures after the injury, if there is signs of basal skull fracture. Now, basal skull means the skull base, if it fractures, it leads to either otorrhea, it may lead to rhinorrhea, so there might be CSF leaking out from here. You may get eye signs which are known as the raccoon eyes, where the eyes of the patient may have periorbital contusions like picture. They might be subconjunctival hemorrhage, and they may also have what we call as a battle sign, where on their mastoid process, there again you might see some contusions. So if there are any signs of depressed skull fracture, like on the skull you can feel that there is a depression there, then these things, so seizure, I've already mentioned. Then you talk about loss of consciousness. Now, loss of consciousness and amnesia are also indications for a CT scan, but more importantly, you if they are of age more than 65 and if they are on any anticoagulant, uh, or then the risks further increase, and then you need to check whether they have any intracranial bleed or any injury, significant injuries. Also, other considerations that can be if the patient lives alone, and there is no one to look after him, and then if you're sending him back home, or if they have very significant comorbidities that like bleeding disorders, uh, that also plays a role in your decision. I could signpost you to look at nice guidelines and the red flags, which can help you in determining when to scan and not. So more importantly, like I would consider a CT scan in any patient who has reduced level of consciousness when they come, have had seizure, or any signs of basal skull fracture, history of loss of consciousness, and if they cannot remember what happened, all these things. So I do a CT scan. Now, after you do a CT scan, the point becomes you need now what happens basically. So There are two things that I want you to understand. Now, we are talking about identifying the damage to the brain, or if there is. Now, a CT scan could come back as completely normal, where reported as no acute abnormality noted. Uh, but there could be a bleed. So, the main things that you have to consider, any acute bleed looks on a CT scan looks, as they say, hyperdense, or it looks whitish, and you should be able to pick it up, or else wait for the urgent radiological report. So an EDH, extradural hemorrhage, could be there. Then there could be a subdural hemorrhage. There could be subarachnoid hemorrhage, or there could be contusions of the brain parenchyma. Now, this is called as primary brain injury caused by the impact itself. So you consider any sort of intracranial bleed, and you also look at the midline. The brain largely should look symmetrical. If there is any shift in the midline because of the bleed, um, that is a very concerning thing. That means the pressure is building up. And when I say pressure is building up, we've heard of the word Monro Kelly doctrine, that the brain lies in a closed, the cranium is a closed space box. Now, what happens is, if now there in that space lies the brain, there is the blood vessels, and there is CSF flowing. Now, a volume rise in anything will compromise the volume of the other structure. So, if there is lot of bleeding happening, so it will press on the brain, and it will lead to increase intracranial pressure. Now, this equation, if you read here, this is mean arterial pressure minus intracranial pressure is equal to cerebral perfusion pressure. Now, what does this mean? Now, your mean arterial pressure is the pressure which is SBP plus 2 dBp by 3. That's the equation, systolic. But usually it is above 65 in any most of the normal grown up adults. And in those cases, a mean arterial pressure you can check by calculating systolic blood pressure, SBP, plus 2 dBp, 2 into diastolic blood pressure by 3. And so that is basically the mean arterial pressure. But the point that I'm trying to explain is a rise in intracranial pressure. Now, this is the pressure by which the the brain is getting the blood. Now, if in that space there is rise in ICP, so that means your cerebral perfusion pressure will decrease. Now, cerebral perfusion pressure is the pressure which is required to perfuse your brain. Your brain needs good amount of blood. Now, what keeps you alive, what keeps all the organs alive, is continuous supply of blood and oxygen to keep it alive. So as the cerebral perfusion pressure, if it drops to less than 70, then it causes problems. But in the emergency settings, all you need to think is, if somebody with head injury, if they are losing blood from elsewhere and their blood pressure is dropping, that is a cause of concern. Or if they are having signs of raised ICP, which I'll discuss further, then their brain will not get adequate amount of blood, and or will not, the cerebral perfusion pressure will decrease, which suggests that their their brain is not getting perfused adequately, and that means further injury may happen. We also know, or we've heard of the Cushing's triad, where a rise in ICP at a very late point or at a very critical juncture, when it presses onto parts of brainstem, it can lead to rise in blood pressure, and it can lead to bradycardia, which are very late signs. Of course, a person's behavior change or their sensorium would change earlier, but or they may vomit. Now, all these signs be there, but Cushing's reflex, just for you to understand, if somebody is having very high blood pressure and along with bradycardia, that may be a late sign, and that means you need to do something to reduce their intracranial pressure. So anyways, coming back to, so we've talked about the approach and resuscitation. So we've done check the red flags, and so seizure, and also you need to consider if a person has had multiple episodes of vomiting, um, that along with a head injury can also be an indication for, is also an indication for getting a CT scan. I'll take a separate talk on the red flags, a small short I will create about it. However, so as I said, the primary brain injury is the injury that is caused by the initial impact, because of which any sort of bleeding can happen, depending on which blood vessel has been affected. If it is, it can happen below the dura, so it could be subdural hemorrhage looking like a concave where bleed. It could be extradural hemorrhage. It looks like lanceolate or lens shape, biconvex, and or it could be SH. We've talked about that. Now, the most important thing is, now we've identified that okay, there is a bleed and there is a problem, but we need to manage. And what do we need to manage? Now we'll say, oh, head injury, let's straight call the neurosurgeon, let's straight, but they may take, any specialty may take time to come. What you need to manage is minimize the damage or prevent the secondary brain injury. Now, secondary brain injury, the two questions that you need to ask yourself is the brain getting blood and oxygen? Number one. And the second is the brain getting squished or stressed? So, what do you do in order to manage this? Most important, you need to optimize your ABCs. So, if a person has a GCS of 8 or less, you could consider intubating them. Optimize that, they are not hypoxic, so they are getting good amount of oxygen, because only when, so that ensures that there is enough oxygen in the system. And then C, circulation. So you need to ensure that they are not becoming hypovolemic, their bleeding is controlled. So optimize their vitals. You don't need to reduce the blood pressure, as sometimes people think that if the blood pressure is too high, it may be problem. In the initial resuscitation bit, you don't need to do that. What you need to focus is to optimize the airway, breathing, circulation, ensure the vitals are okay. Now, howsoever the patient is, if they are alert, make them comfortable. So why I say that? Because making patient comfortable, giving them adequate pain relief is important, because it also a comfortable patient, if a patient is quite uncomfortable, then that can also further make their ICP raise. So give them pain medication. If they are intubated, then sedate them appropriately. A patient who is intubated and not sedated well, so their ICP can increase, causing further damage. So making patient comfortable, as I said, to avoid hypoxia and hypotension is your main concern. Avoid hypercapnia as well. So what you're doing is just ensuring that good, the blood flow is happening nice and the blood is enriched with oxygen. So that is all that you are focusing on. And the ventilation rate is also not too slow, so that the CO2 doesn't build up, because if hypercapnia builds up, it causes cerebral vasodilation, so that also can further squish the brain if the vasodilation is there. Now, if the patient shows signs of raise ICP, but that is a later thing. What you need to do is, you need first ensuring that the ICP doesn't rise too much. So what you do is, you made the patient comfortable, as I said earlier. You could consider head end elevation on the patient. If the patient has shown that there is an intracranial bleed, then you could give prophylactic anti-seizure medication. Um, Now that's something that can be debated, but if you the point is that the patient can have a seizure, and you need to ensure that the patient, if you could give them some anti-seizure medication to prevent it. And if a person is showing signs of getting to bradycardia, if they're intubated, sometimes people, what they do is hyperventilate so that their PCO2 levels their go down, and so that the cerebral vasodilation doesn't happen. But you could give them mannitol or 3% or hypertonic saline, which also help in reducing the ICP. So these are the things that you could consider in when you want to manage the ICP of the patient. So overall, and what you're trying to do is maintain a good balance, a good flow, so that the brain, whatever injury has happened, now the brain is uh, is getting good amount of blood and oxygen, and is not getting squished or stressed. So you maintain a balance. So you try to maintain an homeostasis of the system inside. You can get a blood gas and see that all the electrolytes, pH, PCO2, O2, they are all fine. Maintain a normothermia, maintain euvolemia. So everything in balance, maintain a balance of electrolytes is all important. You could consider tranexamic acid if the patient is bleeding. 1 gram of tranexamic acid as recommended in advanced trauma life support. You could do that. You could give them IV antibiotics if there is an open head wound, and consider tetanus prophylaxis. Now this is the part of identifying and managing. Now you've done all the things that you needed to do. You've got a CT scan. You've done all these things in order to just ensure that the secondary brain injury doesn't happen, or doesn't the injury doesn't get worsened. Now, as soon as, of course, the CT scan is done, you don't need to do things serially first. You do all of this. You can always get the neurosurgeons if there is any abnormality reported on the CT scan. Always consult neurosurgeons, and based on and then their input and your plan, as a combined team decision, you can decide whether the patient goes to operation theater after that, or is the patient, if their GCS is low, then they might need ICU base care. Of course, if they are intubated, then they will definitely need ICU. If they are not intubated, then they might, in patients with, say, minor to moderate head injury, may be sufficient with the ward based care. So this is the point at which you have now consulted, made a plan, and decided to move the patient. But then, if it comes to a point as to could the patient go home? Now, as I said, this patient has arrived. He had a big head wound. Now you control the bleed. You then also the patient remained alert throughout. He did not have any vomiting. He did not have any seizure episodes. He did not have any red flag signs. So you did not. So no red flags were identified. So you may think, now I could send him home. So if you are ever thinking of sending someone home, these are things that you should consider, so that there are no red flags. Now, if there are any red flags, the patient should have a normal CT reported. Then they should be alert or at their functional baseline. Now, if somebody is, say, very elderly who has had a fall, but their usual GCS is 13, 14, something like that, that they're usually drowsy or confused, then you need to ensure that they are at their usual cognitive and functional baseline. You need to check that are they safe to go home. That means that is there a responsible adult at home who, if the patients in the first 24 hours if there is any deterioration. Now, you at that point you said, okay, everything looking fine, and you could say, okay, we can send you home. But if their condition deteriorates, now if they become drowsy or if they have a seizure, then uh, that is a problem. So you should ensure that there is somebody, a responsible company at home when they go home. And very important, the primary issue, what happened? Why did the patient have a head injury? Was it because he became unconscious? Did he have a seizure? Did he have a syncope? So any primary, if there was any primary issue, was it just like a injury, he slipped and fell, then that's a different thing. um, but if it was a medical cause that led to the head injury, so that needs to be identified as well. So overall, you need to think of the patient as a whole, holistic management of head injury. And as I said, when you are planning to send them home, you should always safety net them, make them alert of all the red flag sign. So tell them if they have um, uh, any any of these issues here, like seizures, or their arm or leg becomes weak, or if their vision becomes blurred, or if they have multiple episodes of vomiting. And now a lot of patients will complain of severe headache. Now the point is, the headache is not a criteria to do a CT scan. But if the pain is just worsening, and you could tell them to take paracetamol or simple ibuprofen based on whatever suits them, so they could take that, and remain well hydrated, sleep appropriately. But you advise them this. But if their pain worsens, then they could, you can tell them if there are any red flags coming, or if the pain is worsening despite of all of this, then also they could come back. And as I said, having tell them not to drink any alcohol or take any medicines that, or that are neurodepressant. Basically, they can take all of their regular medicines. Yes, if they are on anticoagulants, you need to consider that those anticoagulants should be stopped for at least a week, because patients with anticoagulants can have a delayed onset of bleeding. And as I said, sending them home with a responsible company. So this in all is how you would manage a patient with head injury. It may look a bit complex, but usually if you follow a systematic approach, taking the patient as a whole, and then understanding that controlling bleed is important, wound closure is a later priority, and then identifying the when to do a CT scan, that's an important thing. And then identifying what is the injury, managing and preventing the secondary brain injuries by ensuring a good flow of blood and oxygen throughout, and ensuring that the patient is comfortable. So you do all of that, and then consulting with neurosurgeons, deciding where to move the patient, what would be the definitive plan, and counsel them appropriately when you have to send them home. So, this, my friends, is how you should manage a head injury. I would be happy to take up any doubts, and I will be preparing shorter, smaller shorts or lectures on it, so that it helps you further. So, that's all for now. Thank you so much.